Okay. I think some folks are going to keep trickling in, but I just wanted to introduce you and welcome you to the scientific portion of the program. For those of you who don't know, this is actually the 30th ACRO annual meeting, so a nice milestone for ACRO. This meeting, as Sheila alluded to, has had record attendance, 380 registrants, which is up about 100 folks from last year. So it's an increase by 35%. So I think ACRO is seeing some wonderful growth. As mentioned, as part of the program, there's some novel aspects. There's a new track called SEAL, or Sharing Excellence Amongst Leaders, which are administrators. There are about 60 administrators who've come for this portion of the program. We have about 100 residents attending this year and about 100 abstracts submitted. All of these, I think, are important records, actually, for ACRO. In terms of just kind of guiding you a little bit at the scientific program, you're going to see an oral presentation session this afternoon. There's also one on Saturday morning. There will be poster walks as well on Saturday. Please feel free to join one of the 4 poster walks on that day. And then there'll be abstracts that you can visit throughout the day on Saturday as well. As was introduced earlier, this is the first time we're using a conference app. And so if you haven't already done that, please follow the instructions on the back of your name badge. If you are having any trouble, the staff is available at the registration desk to help you with this. But you can actually follow through the slides on the app. And very importantly, this is where you're going to get your SAMs as well. So the SAMs quizzes are taken via the app this year. And if you go to the home page, once you've downloaded the program, and you scroll down, you'll see the blue SAMs quizzes button. And each session that includes SAMs will be listed by the day and time there. And it will be available during and after the session. We're going to close the SAMs, the completing of SAMs, on Sunday. So that allows folks who may not have a device with them, or if the internet is working a little bit slowly, to still have a chance to capture the SAMs. So if you haven't done it by the end of this session, don't freak out. You have still a few days to get it done. And again, please talk to the folks at the registration desk for any help with that. The overall conference evaluation will be there as well. And that's also where you're going to be able to download and then print your CME credit claim certificate, okay? So everything is via the SAMs this year. Just a very quick word of thanks. This is my 3rd year as the scientific program chair. I had the pleasure of doing 2 of those years with Stephen. When Stephen rotated off, I spoke to Joanne and Sheila and said, I really need some strong co-chairs. And I couldn't have been luckier in the choice that I had asked for. And that was 2 folks who'd been on the scientific program committee that were working very hard for a few years. And that's Parul Berry and Brian Lally. They're over there, and just a little round of applause for those 2. Parul really has brought a positive and can-do attitude for many, many years now to this committee. And Brian, I mean, he has some raw and unleashed enthusiasm. And I think, he should be particularly noted for that, and he has really been behind a lot of the growth that you're seeing at this year's ACRO meeting. And so, yeah, no, it's certainly a big team, but I wanted to note those 2 folks. In terms of the team, the scientific program committee is awesome. I'm not going to name every individual here, but there's also an abstracts committee that was led by Stephanie Weiss and Larry Kleinberg. There's a residence committee that's been led by Kyle Stang and Ashlyn Everett. There's a number of other things you'll see in the program. Please look at this and attend those that are of relevance and interest to you. There's the Women's Forum. There's a new practitioner forum. There's e-contouring that, thanks to Erin Gillespie, has been an amazing success recently, and as we're offering again this year. There's a very robust residence program. I know they've asked a number of faculty to join their program as well. There's also a diversity and inclusion program. So please do attend those aspects of the program as well. So your job as attendees is to enjoy this rich program. We've revamped it this year. Shorter sessions, 1 hour. You're getting more speakers quicker, a little tighter sessions, hopefully. We're offering 22 CMEs and 15 SAMs, which again is a record, and we've been able to do by tightening the schedule in this way. So your job is really to enjoy the incredible speaker lineup that we have, engage in the discussion. And lastly, I know she's probably at the registration desk. The team here, there's an interim executive director, Shannon Bozarth, and her team have done a phenomenal job picking up the ball and helping us run this program. And so when you walk by that desk, please thank that staff as well. With that, and with no further ado, I'd like to just move us along to the next session, which is going to be very strong and picks up on our keynote address very nicely. This is Making Practice Administration Great Again, and I'd like to introduce Brian and the team.
So my name's Brian Lally, as Jason introduced. Come on up, Kim. And this is Kim Cummins-Sumakis from 21st Century, and we're going to be the moderators for this session. We wanted to build a session that was a little bit different, but had followed a little bit up on what we have discussed with the keynote speaker, and kind of focused on the parts of our practice that are kind of a little bit outside of our normal comfort zone, and offers us areas to make our practice great again, is why we came up with the title. And with that, I'll turn things over to Kim and let her introduce the first speaker.
Thank you. Good morning, everyone. I'm excited to be here and excited to hear our next presentation. It is my pleasure to introduce Dr. Justin Bekelman from Penn. Dr. Bekelman, as many of you know, is an associate professor in both radiation oncology, medical ethics, and health policy at the Bekelman School of Medicine. He is also the director of the Penn Center for Cancer Care Innovation at the Abrams Cancer Center. Dr. Bekelman's research focuses on healthcare delivery, payment reform, and cancer care transformation, integrating methods from the field of innovation, epidemiology, clinical trials, behavioral and health economics, and public policy. Dr. Bekelman has over 100 publications with multiple manuscripts in high-impact scientific journals, including JAMA, New England Journal of Medicine, Lancet Oncology, JNCI, and JCO. His work has been funded by the National Cancer Institute, the American Cancer Society, and the Patient-Centered Outcomes Research Institute. He has served as an advisor to the Centers of Medicare and Medicaid Services on cancer care payment reform and innovation. Today, he will talk about the concepts of an episode of care payment model, which we're all anticipating greatly. But before we do that, with all of your success, I think joining 21st Century Oncology might be the next best step for you.
Hey, Kim, now, these property is Penn Medicine. Get your hands off.
Thanks very much. Thanks, Kim. Thanks, Brian. It's a real pleasure to be here today to speak to you. Let me start with a story. About 10 years ago, I learned about a woman with early-stage breast cancer. This was in 2010. She owned her own business. She was a psychologist, and she had a lumpectomy. Went to the radiation oncologist who recommended the standard of care at that time, which was 7 or 8 weeks of radiation. And she went to the doc and said, you know, the New England Journal of Medicine just published this article that showed that that you can do it in 3 weeks. Why are you recommending 8 weeks? And they engaged in a great conversation, and she was the first patient that he chose to do hypofractionated radiation for. And this is a good story. It's a happy story. It demonstrates shared decision-making. But it's that kind of story that made me think about what does it take to change practice? What does it take for clinicians, physicians, and our allied health professionals to think about clinical transformation? What does it take for patients to think about it as well? And now, fast forward 10 years, and I've spent a good portion of that time as a practicing radiation oncologist, as someone who researches and is sort of a scholar of how we practice, and also the leader of our Cancer Center's Innovation Center, thinking these issues through. At any given time, our Cancer Center's Innovation Center has about 24 innovation programs across medical oncology, surgery, and radiation, where we're effectively testing different models of clinical transformation. And I say the major learning I've derived from that is humility. It's really challenging for us to change practice, even in light of evidence-based practice and the articles that come out. And there are lots of reasons for that. And it's in that context that I'm speaking to you today. And I think it's also important in light of the discussion we just had from Dr. Ritter that I share with you that I served as an advisor to CMS and to CMMI in 2017 and 2018 on the radiation oncology model and also on other models that they were doing. This was a paid consultancy. And it really helped me, it informed my thinking, I would say, about how we change practice. But I think it should come as no surprise to you that I endorse episode-based payment for radiation oncology. It should also come as no surprise that people can disagree about how that should be implemented, how that should be executed. So I might take a different point of view on what actually is going to come out after my service there ended in 2018. But it's important in the context of this conversation today and dialogue that you hear from me that I endorse conceptually the idea of moving from fee-for-service to episode-based payment, from volume to value, and that it's not personal, that this is something that I think is important for American medicine. I happen to be a practicing radiation oncologist like you all are in the room, and so it feels sometimes personal to us, but this is something that's happening across medicine. And so in today's conversation, what I'd like to do today is give you a sense of, number one, how I think conceptually about how payment affects practice. And the takeaway, the headline there, is that there's actually no right answer. Whether you're doing fee-for-service or episode-based payment, both of them have good attributes, and frankly, both of them have bad attributes. And we have to be cognizant about the wrapper within which we practice. What I'll also do is talk a little bit about the CMS model, but it was just presented, so I'll skip over that just for time. And then talk to you about one of those 24 projects that we're working on in the Innovation Center, which is a live, prospective, episode-based payment model for radiation oncology that we're doing at Penn Medicine with Independence Blue Cross, which is our large commercial insurer in our region. I'll give you a sense of some of the learnings that we've had from that. And I'll end with something that I think is really important, which is 5 strategies that I think I'd like to share with you about how to be successful in these models. So with that context, let me give you 2, they're not really opposing, but they're complementary views on how we practice as physicians. One is the classical economist view, who would say that physicians are rational. We're driven by income, leisure, and conscience. And then, of course, I've added training norms. And I think that characterizes almost in a stereotype or caricature of how a physician might practice. And so under that caricature of physician practicing, we might target payment models to change practice. And I think that's the lens with which most payers, insurers, including Medicare, sees the power of their payment model to drive practice change. But there's a complementary view, and that's the behavioral economist view, which describes an alternative way of human behavior. We're not just motivated by financial incentives. We're predictably irrational. Our decisions are affected by what's called heuristics or mental shortcuts. And so you have to target these mental shortcuts to influence behavior. And I see this in our own practice. We get into therapeutic lanes. I practice for these types of patients with stage blah, cancer blah, in this way. New evidence comes out, and I get out of that lane, and I go to a new therapeutic norm, and I get into the new therapeutic norm, while some of my colleagues might be stuck in the old lane, in the old therapeutic norm. That's actually a heuristic. It's a mental shortcut. And that behavior is actually explained more by behavioral economics and less by incentive theory or health economics. So given that context, and we're going to get back to that amongst those 5 strategies I'll share with you, how might we look at fee-for-service and how might we look at episode-based payment? So fee-for-service, if you're an egg-headed economist, you'd call it piece rate payment. So that means that the payment is directly related to the volume of services provided. So in radiation, 90% of the global payment that we get, and I'm using that term loosely, global payment, the universe of money that comes into our organizations, whether we're hospital-based or outpatient-based, is per fraction of treatment, is the technical fees. Well, what are the cons? We know the cons. It's over-delivery of care. Well, let's look at episode-based payment. So this is what the radiation model is about. It's other terms for this: pure prospective payment, provider cost sharing. I like that term because there's some irony there. It's a lump sum payment. It's independent of the services delivered. What it means, and this is so crucial, is that the marginal cost of care is borne entirely by providers, either physicians or hospitals or the owners of the equipment. So as treatment costs rise by $1, provider income falls by $1. That's a really powerful incentive, just as powerful as the fee-for-service incentive. Everything highlighted in red is important for your questions on your iPhone, just so you know. So pros, the pros are efficiency. That $1 up, I lose $1, makes me practice in a really efficient way. The cons, there are 4 of them, and they're really important to understand. It's not all good. Number 1, stinting on care. That powerful incentive can induce providers to not give the correct care. So instead of having overuse metrics, we're going to need underuse metrics in episode-based payment. There's cherry picking. I just want to find those patients who are really healthy where I can hypofractionate in the safest fashion, rather than the more complicated patients where hypofractionation might be challenging and I might lose $1 as a result. Avoiding high-cost, effective treatments just because of the cost, rather than understanding that these are actually the more effective treatments, even if they're more costly as well. And then induced demand. That's the idea as well. If I'm being paid by case, rather than extending the number of fractions, I'm just going to get more cases. That gets into an overuse concern, for example, for women with breast cancer over the age of 75, whereas under fee-for-service, I might not have treated them under episode-based payment. Well, maybe she might benefit, and maybe I'll introduce the way I talk about that local recurrence rate differently because of the way that I'm paid differently. So those are really important attributes to these 2 different payment systems that I think is not only important for us to recognize, but also important to state implicitly that it's not like episode payment is better than fee-for-service. They're just 2 different ways of paying, and they both have pros and they both have cons. But what's at stake? What's at stake? So this is not only about that conversation that I shared with you with the woman who was asking, in 2010, why can't I get 3 weeks of radiation? This is about suboptimal care. And the latest research shows that a quarter of the $3.8 trillion the U.S. spends on healthcare today is wasted on suboptimal care. Just to give you a sense of that, if we got rid of suboptimal care, we could not only get rid of patient out-of-pocket expenses entirely, we could actually pay patients to get good care. That's the quantity of money we're talking about. If we got rid of suboptimal care, we could actually pay for high-cost innovative treatments like the $1 million gene therapy, the $1 million CAR-T, right? Expensive radiation modalities that may actually be beneficial when the evidence comes out. That's why this is important. That's what's at stake. So in that context, we have the radiation oncology APM coming out. Folks are familiar with this, so I'll go through this briefly. But the basic goal is to test a pure prospective, site-neutral payment for radiation oncology. This is a case rate. That's what the experiment is. It's important because it's prospective. It's important because it's site-neutral. as Dr. Ritter said, there are some elements to this model that CMS is using to understand, can we do it elsewhere? For example, prospective payment has benefits to cash flow to us as providers, but they've never done it before. So there are real important lessons, not just for radiation oncology, but for payment through Medicare that motivate this model. In terms of the radiation oncology model, I'll just briefly note, especially the writing in red here, that it's a prospective episode-based payment that measures quality. That's the effective summary of this model. If there are specific questions about the model, I'm happy to engage with you on that, but I know what you know at this point. My engagement with CMS formally ended in 2018. The model was developed in 2019 and released on that time course, and so I have no other sort of private or public information to share. As a result of the CMS, not the CMS, well, it was from CMS, as a result of that report to Congress, we at Penn began to appreciate how important it was to begin to think through, what does this actually look like? Pure prospective payment, bundled payment for oncology. So we approached our local payer, Independence Blue Cross, and said, you know what, let's do our own test. And this is where the meat of the talk really gets, I think, most important in terms of takeaways. We are now currently engaged as of August 1st, 2019, in a demonstration project with Independence Blue Cross. They brought in Evacor, and so it's done through a contractor, and we can talk about why that is, but that's how it was done. It's focused on commercial plans only. It's diagnosis-based, just like the CMS model, breast cancer to start. All modalities are included. Proton beam, as you all, Penn Medicine, as you know, is a proton beam center. Proton beam's included here. 4 hospitals and licensed sites are included. So our footprint is actually 6 hospitals, but for various reasons, they're outside of the model at this point. 7 total sites, hospital and community-based regional network sites are included. It's a lump sum payment in two installments, and it has quality metrics. So it's like a mini version. There are some elements that are a little different, but it's like a mini version of the model. And what I can tell you is that it's been really hard. It's been really hard. We've gotten a ton of learning from it, and I can summarize it in 3 different areas. Number 1, change management. Number 2, information technology. And number 3, the partnership we have with the insurer. So in terms of change management, through this model, we've supported our physicians in making it frictionless, and I'll talk more about that, to do high-value care. Frontline office staff and clinicians have all needed information to be able to be prepared to talk to patients about what this difference in payment means, both to their insurer, but more importantly, to them. Why? Because it's very possible that their out-of-pocket expenses will be delivered instead of on a weekly basis or a monthly basis in 2 lump sums. That larger number, even though it's the same as what they might have paid anyway, could have an impact on how the patient thinks about their treatment. All of that yields this idea of change management. This is what our field's going through right now, and this investment is what's crucial. Information technology. It took us quite a bit of time, a cast of a dozen people, to change how we receive payment prospectively under a lump sum model. It turns out Epic, the information system we have, has a lump sum payment module that we actually had to purchase. It wasn't quite right. We had to tailor it. It's the first prospective payment system that we've had in our entire health system. So we're using it as an institution, not just to experiment in radiation oncology, but to draw lessons across our book of healthcare business in terms of how we take payment prospectively. And in addition, in terms of innovation, what it actually takes to pull something like this off. And then the partnership with the insurer, I can't emphasize this enough, that this partnership has demonstrated to us that the insurer is going through as much pain as we are. They have their own pathways of doing payment processes. They have their chassis, as Dr. Ritter said. This is all outside of their chassis. That's why they're actually using a contractor to do it. But even within that, it's very difficult for the insurer to move to this model as well. And we've shared some of these insights from actually on-the-ground learning with CMS. So with that context, I'll end with these 5 opportunities. And what I'd like to do is just have us think back to the woman we started with. So that was, again, 10 years ago. The literature was out, but it wasn't fully informed or reinforced by the now 4 or 5 trials that have come out. There was a high-profile article, New England Journal of Medicine, supporting the use of this treatment, and it was very appropriate for that physician at that time to say, you know what, 8 still, or 7 weeks, it's still the standard of care. But what does it take now in 2020, not just in breast cancer, but in prostate cancer, in bone metastases, or in other areas where complexity of care is not actually warranted, or extended fractionation is not actually warranted? What does it take to change practice? Number 1, under bundled payment, we have to dramatically increase efficiency while maintaining highest quality of care. So the models not only have to turn on a dime to change payment, but they have to measure care because the incentive, rather than over-treatment, is under-treatment. And as providers, we have to be attentive to those motives and implicit biases that could yield cherry-picking or stinting. Dramatically increasing efficiency, actually as physicians, we're going to be thrilled about this because it's, at least here at Penn, sometimes I find it's really hard to do my job. But if we have people working at the top of their license, if we provide efficient care, that actually makes our life better. We should be doing it under fee-for-service. That goes to number 2, make high-value care frictionless for clinicians and patients. Also crucial, it shouldn't take me 5 clicks to order the right treatment for that patient. If anything, the right treatment, if it's a standard case, should pop up for my signature. That kind of frictionless healthcare that's baked into the EHR, that uses an EHR not as a bill coding machine, but actually as a clinician productivity tool, is the opportunity for frictionless care that can actually transform how we practice. Number 3, align clinician financial and non-financial incentives to payment models. So at Penn Medicine, part of my compensation is related to the RVUs I generate. I think that experience is shared for other folks in this room. If we go under a bundled payment model, that's completely misaligned. So institutions have to begin to think, how do we align payment to our clinicians so that the incentives with the payment models are aligned? And how do we do that when some parts of our healthcare book of business are under fee-for-service and other parts are under bundled payment? Really complex, but important to actually engage in the discussion. Number 4, accelerate team-based care. This goes to efficiency, but it deserves its own point. Advanced practice providers, nursing team, care coordinators, navigators, if they're not working at the top of their skills in your organizations, and they're not always in mine, they need to be in order to provide the most efficient care, but also the highest quality care for your patients. When my organization is thinking through, well, how do we sort of win or how do we succeed? It's not just about efficiency. It's also about helping each member of the team contribute to their maximal potential so that, frankly, the physician's time is not wasted. And number 5, partner and innovate together with commercial insurers. I don't know if the model is coming. I've heard the same rumors that you've heard, but I can imagine it's coming. What I can also imagine is that the commercial insurers, whether they're national or local or regional in your market, have heard about the model as well. And they're ready to hear from you. They're ready to hear that you're interested to talk to them about what it might look like, to even test models with them. Even amongst, radiation benefit managers, of course, have their own reputation in our community. But as they're thinking about bundled payment opportunities, I would encourage you at least to engage the conversation with them, because all of this is giving us lessons and experience for what I think all of us will see in the future. Thank you very much.
Okay, I just want to say thanks again to Justin. And I'm also, I love this session because two of my favorite radiation oncologists, of course, everyone here is my favorite radiation oncologist, will be presenting. Our next speaker is going to be someone that I had the opportunity to work with at Wake Forest. I was very upset that she came on as I was leaving, and we only overlapped by about 7 days. And I still regret leaving Wake for that missed opportunity. Karen Winkfield is an associate professor of radiation oncology at Wake Forest, as well as the Associate Cancer Center Director for Community Outreach and Engagement. And she has really great ideas. And I'm so jealous that she actually gets to put them into practice and see them operationalized. And she's going to tell us a little bit about what she's doing down in North Carolina. And please come on up, Karen.
Good morning. Oh, come on. Good morning.
Good morning.
All right, very good. So thank you so much, Brian, for allowing me to come and definitely share a little bit of some thoughts, because I think the keynote and also Justin's talk really highlight some of the challenges that we're going to be facing, right, and really currently are facing with respect to really having our mission match the money, right? And so I did not select the title of this session, and I reject it for some obvious reasons, the one that you picked. So here's my title, Matching the Money to the Mission. And, one of the things that, let me just make sure I know how to, is it the green? Am I advancing?
I believe so.
Oh, Lord, here we go. So yes, I'm the Associate Director for Community Outreach and Engagement for the Comprehensive Cancer Center. As many of you may know, the NCI has really taken what used to be a huge love of mine, community outreach and engagement, and muddied the waters a little bit, now focusing their attention mostly on research and how to engage communities in research. And while I do some of that, I'm going to share with you some of the things that I'm very passionate about. I do not have any financial disclosures, unfortunately, but I am willing, so I have cards. I do, however, have a disclaimer. Last night I was dragged kicking and screaming to this place called Lips, which anyone, and there were queens that were there, and there were kings that were there. And in fact, these slides are in your app, so download your app. And we did get jewelry, so I have my jewelry. I didn't go to Mardi Gras this year, I went last year, and actually my beads were bigger than, where's Sheila? My beads were bigger than yours. But I will wear my jewelry for today's session because, we have to do that. So, as you know, SAMs, this will be the trigger. You'll see this anytime that we have a SAM that's gonna come up. And so here, what is your mission? How many folks have like a vision statement or something that they live by? Okay, maybe a few people, right? I think, those of us who are in medicine, we tend to be pretty driven in terms of what we do and why we do it, and we may have personal mission and vision statements. But all of us work for institutions and practices, and there is a mission. Now, how many folks have seen the mission statement for their department or division, right? Okay, very good, very good. Now, it might look like this: to make as much money as possible, irrespective of the care our team provides to patients. Yeah, no, that's not it. But here are some that I actually grabbed off of the internet. This one: dedicated to providing the most advanced cancer care available anywhere In an atmosphere of caring compassion. It sounds so lovely. In this one, we are committed to providing state-of-the-art, academic quality radiation therapy and other cancer treatments in a patient-centric setting, focused on continuous innovation. Now, there are several key words in both of these statements that I want to highlight. Advanced cancer care, state-of-the-art, quality, innovation. Each of those words actually mean capital expenditure, right? There's an investment that necessarily needs to take place, right? If you're going to be talking about being innovative, if you're going to talk about bringing state-of-the-art. But then you juxtapose that with also thinking about caring, compassion, patient-centric. So how do you do that? Because in some ways, sometimes the two may not be the same. So today we're going to talk a little bit about balancing the profit with mission, whatever the mission statement is of your organization, and really thinking about how do you make the money match the mission. So I'm a specialist in health disparities, so my research has really been focused on how do you make sure that everyone, regardless of who they are, with their race, ethnicity, geography, that they have the capacity to have survivorship, right? We want to survive well, right? So how do we do that? This slide, I put this in my deck all the time, just remind folks that the top 4 cancers we've got in the United States, lung, colorectal, breast, prostate, that while we have slight increase in terms of incidence for most cancers for African Americans, prostate cancer is way off the chart, as you can see on the left-hand side in the red, where they're much higher incidence. We know that across the board, African Americans are dying of these cancers at a much higher rate. Why is that? And what the heck does that have to do with money? Well, we know that health disparities are described by the NIH as adverse health conditions, and that can mean a whole lot of different things. There's socioeconomic, there's all sorts of other reasons for adverse health conditions, and in fact, they don't just impact racial and ethnic minorities. So yes, I showed you a slide that kind of alluded to the fact that African Americans have higher death rates, but trust me, there are other types of racial and ethnic minorities that are actually struggling with respect to cancer outcomes. But we also know that there's geographic. Okay, so how many of y'all practice in a rural setting, or the majority of your patients are coming from rural? Okay, handful of folks. Can I tell you, my mind was blown when I moved down to North Carolina 4 years ago. And 59%, my job as the associate director of the cancer center is to say, how do we define our catchment area? How do we define where patients are coming from? 59% of the patients that are coming to me are coming from rural areas, 59. And we do not have Medicaid expansion, won't talk about that, which means I have counties where 20 to 30% uninsured rate. So people are coming, and we're the closest comprehensive cancer center. You got Duke and UNC who are on the eastern, or kind of more mid, or to the eastern part of me, or east of us, and we'll have people who are driving 200 miles or more to get cancer care, right? So again, we know that adverse health conditions can exist in a variety of different ways, and we got to think about the sexual and gender minorities, LGBTQ plus population, adolescent, young adult, oftentimes an overlooked population, but can you imagine being 20 years old and kind of developing Hodgkin lymphoma? You're right there in college, like what the heck, right? And then you have all of the sequelae from that. But a lot of that, what underlines these groups is lower socioeconomic status. And in fact, the greatest predictor of health is indeed socioeconomic status. And there are 3 components to that: income, occupation, and education. This is a fantastic series. If you haven't watched it, on Unnatural Causes, there are about 7. It's on PBS. It really talks through the economics of health. And I always tell people, wealth equals health. And when you have disenfranchised communities, that can absolutely impact their health and well-being. Yet you, as the radiation oncologist, you're responsible for outcomes, aren't you? Despite all of those issues. We know that financial toxicity exists, right? We hear about it. It's become a coined phrase that we hear about over and over again, the financial toxicity. And a lot of times we're talking about patients. Originally it had been looked at in practices, and we can certainly talk a little about the financial toxicity of caring for people, giving free treatment to people, right? We all do it. Because we have to. But who should intervene? This is a slide that I actually used at my talk at ASCO last year. We're really looking at something as universal in some ways as lenalidomide, which is a drug that's used for multiple myeloma. I'm a heme radiation oncologist. And it's ridiculous, the out-of-pocket cost. And look at what's happening with Medicare. Remember, Medicare only covers 80%. And so you have families that are paying out of pocket over $12,000. Remember, the federal poverty level is $24,000 for a family of 4. We forget that sometimes, what poverty is and how low the bar is to really take care of families, right? So this issue of social determinants of health is really critical in terms of how we go about our practice, because I love this slide because if you look at the maroon-colored, wedge that's in this pie chart, that's medical care. So how are we supposed to be responsible for outcomes when from a population health model, only about 25% of health happens in the context of medical care? You have all those other things swirling around that impact and influence. So how in the world can we make the money match our mission when indeed we have to start thinking about what's happening before a person even walks through our door? How do we do that? And this is an example. So this is breast cancer, right? If we look at urban versus rural, so non-metro rural, and we look at incidence of breast cancer, that's the blue chart, the one that's on the left in each of these bars, the incidence is higher in metro areas. Incidence of breast cancer, why might that be? Think about it. Okay? It could be a couple of different reasons, right? But some of it might be even access. Maybe we just don't know. Maybe people aren't getting screened in rural communities, right? How about that? But we know that the outcomes are worse for individuals in rural communities. Again, why would that be? A lot of it's access, right? You think about how many of your patients are going to drive every day for radiation therapy when they're driving 200 miles a day. It's hard, or each way. And then I already showed you this on race and ethnicity, but here is a slide that came out of an article that's in the AACR, and again, this is in your notes. You'll see this on your app. What are some of the causes of breast cancer disparities? And with respect to race, ethnicity, geography, et cetera, a lot of it is actually related to inadequate treatment, inadequate radiation therapy, inadequate chemotherapy, inadequate targeted therapy. But you know what? One of the largest issues that we face is actually not only having biologically aggressive disease, but delayed diagnosis. So here you are tasked with outcomes. You've got to figure out how do you bring quality as a radiation oncologist when you have people coming to you with locally advanced breast cancer, right? And what does that quality mean? And how do you measure that? And who's going to be responsible for talking about the measurements, right? Those are all the things that are really important, but yet we're being tasked with doing it with having our budgets kind of shrinking, right? And so the cancer control continuum is really long. You have prevention and all sorts of other things, but then there's detection and diagnosis. We sit in a treatment space, and yet we're still responsible for the outcomes that are really related to the entire cancer control continuum. So it's really important to figure out how to do this. In this slide, yes, there's some personal responsibility, but policy is really critically important, and certainly community. And so briefly, I'm going to go through and talk a little bit about community. This is my team. I have a team of 8. I have 8 people working with me to figure out how to take better care of patients, right? We have population health navigation, which is an important part of making sure that we are putting people in front of communities that look like them, right? So I have a person who's focused on rural, a person who's focused on African American, a person who's focused on Hispanic, and then I just received a $500,000 grant for adolescent young adult, right? So we want to make sure that people see people who look like them and understand their context so that we can help them navigate. We do things like things that help reduce cancer burden. We do cancer screening prevention, tobacco cessation. We do stakeholder engagement. We sit in meetings. We talk with American Indian populations. We're sitting down with the African Americans and doing town halls. We have patient support programs. I just told you about our population health. I've been able to raise an endowment, so now we have philanthropic funds coming in all the time. We have survivorship care, right? I can go on and on and on, but you know what? It took money, right? So over the past 3 years, I've raised over $1 million in funding, and this matches the institutional. I have a budget. I have an operating budget of over $1 million, right? These are matching funds in addition. How many of y'all have $2.4 million, right? How many of you guys have $2 million laying around that you can start doing programming, right? If you do, come talk to me later. Like I said, I'm available. Okay. Community engagement is going to be really important when you start to think about how do you drive quality? How do you make sure that we are taking care of people? How do we bring patient-centered care? And I'm not talking about this type of community engagement, even though, Brian, you do wonderful talks in the community. Thank you very much. These are 3 simple steps that have been identified. So this publication, which again you'll have a link to in your slide deck, came out of my office. So Dr. Weaver, who's a rural health specialist, and Carla Strom both were instrumental in getting this publication out, really talking about 3 simple steps. The first is engaging the community, and then having them help you assess to identify the problems, right? So you have to engage the community. I think a lot of times in academia we say, oh, look, this is a problem, let's go fix it. And you have to engage the people for whom you want to try to serve, right? I mean, it seems like it's a no-brainer, but we don't oftentimes do that. And so really community engagement is the first step. So I'm gonna go very quickly because again, you have each one of these resources. So what I wanna do all the time is talk about what resources do you have locally, in your communities, near your institutions that really can help you take excellent care of patients. So don't forget your local organizations. Think about American Cancer Society, right? Transportation is the #1 barrier to care. I saw it when I was at Boston, when I was at Mass General Hospital, working with Dr. Staffew, right? Transportation was the #1 barrier to care, and it is in rural communities as well, but American Cancer Society provides transportation and other things. So make sure you're tapping into your local organizations, including your faith-based organizations. Don't forget about the Department of Public Health that's local. They also kind of help with transportation. They have other resourcing available, and so partnering with them can be helpful as well. These are some national organizations that I really, really like, and so these can be websites or things like that you can have available to your patients. Cancer Care, they do provide some finance support for patients. It's really, really important in addition to having just information that's online for patients to help them walk through the journey. Same thing, again, American Cancer Society, they do have very comprehensive assistance. And then if you have clinical trials at your establishment, the Lazarus Cancer Foundation actually has a reimbursement program, but that does provide funding for transportation if individuals are enrolled on clinical trials, both local transportation, but also nationally. I mean, they will fly people across the country to enroll in a clinical trial, so it's something to be aware of. Sisters Network, so when you talk about different populations, you may not have a black radiation oncologist working with you, right? And I joke because there's only 3% of us. There are fewer than 20 African Americans who are in academic centers in the friggin' country. And you're looking at one, right? So what happens when you want to provide culturally competent care? You can certainly hire staff, but we might not be able to do that in certain regions as well. Really being able to have resources you can point patients to is really critical, right? So Sisters Network, focus on African Americans. Latinos Contra Cancer is another one for Hispanic, which I absolutely love. Again, they also provide some funding for patients as well. LGBTQ plus populations, really important to make sure they feel welcome at your institutions. It can be harder in some regions of the country than others, but know that there are some national organizations that really focus and highlight on that. So it's really critical to assemble the right team to take care of people. And the biggest team member you can have is volunteers. I can't tell you how vital volunteers are to making sure that your money can match your mission. Because it's volunteer, it's free. And a lot of the volunteers that I utilize are individuals who are just grateful. Cancer patients, right? Somebody's family member, a caregiver that just wants to give back. Find your volunteers that you can partner with, and they will do all of the work, I promise you. And you can provide oversight. And it's one of these ways that we can really start to take all of these issues around quality and drive them right home. Here's the list of resources there. Again, I put my office on there as a resource. We love to partner with individuals. Another thing to make sure that you can do is make sure, this is my AAA, I always have this AAA put in there. Make sure you're aware of what policies in the legislative landscape, your vote matters. Please make sure that you're really looking at the issues that are really gonna impact not only your capacity to provide good care, but what's happening on the patient side. It's really, really important. We've got to become advocates for ourselves. We need to become advocates for our patients, and we need to have great ambassadorship. And I just point this out again because the Medicaid expansion is really a huge issue still for a lot of our country. And so I'm going to leave you with this. Many of you have seen this slide before where you talk about equality and equity, and you see the difference, okay? Not everyone, not all size fits, not one size fits all. And so sometimes you have to provide additional resources for certain communities. But I want to say to you this, that equity is quality. And that's why it's important that we're having this discussion as part of the business portion. And so we need to make sure that our mission is clear and that we find creative solutions to making sure that our money matches the mission. Thank you so much.
I would make more comments, but I'm a little scared there may be more pictures coming out and other presenters this week. And what I was going to do is let Kim take over and talk a little bit from the CEO perspective of these two talks, and we'll take some questions from the audience afterwards.
Thanks, Brian. I want to leave some time for questions, but as I listened to both of these presentations, a couple of things really resonated with what we've spent most of our time as administrators in a large cancer company throughout the country talking about, and that is, how do we give our physicians the best place to work, a quality place to work, while still achieving that mission of staying focused on the patients, remembering at the end of the day, we're all here and we're all doing this because there's a patient population that needs to be treated. And whether that patient population is in a rural, poor community or whether they're accessing the best academic center in the country, we've got to be able to give them the same level of care, the same level of access, and the same level of quality. As a for-profit company, it's something I've been very passionate about making clear that our mission is to treat all patients and to make sure that everyone in all of our centers realizes that. The payment component of this, going to the bundled payment system, is actually something we're embracing and pretty excited about as well. It's a change, and it's obviously making a lot of people nervous about how to structure that. But the focus on quality is where we always should have been regardless, and this is just going to force a continued effort to be more efficient. What does that mean? It doesn't mean that the physician should be working harder or the staff should be working harder. It means that we've got to embrace technology and other changes that allow us to do more in less amounts of time, make the quality of the care better, and reduce the overall cost of treatment. So it's going to be a challenge, certainly not going to be easy for any of us as providers. None of us like change, especially as it impacts money coming in the door. We all, I think, are doing a very good job with the amount of resources that we have in the area of cancer care, and everybody would like to have more, but now is the time to try to take advantage of the changes in technology, the changes in ability to get more efficient on quality care, and make sure that we're doing it in the best interest of patients. And one of the key things that resonated with me was aligning those incentives so that everyone is aligned to do the same thing, because when those incentives are not aligned, then the patient suffers, physicians suffer, and most importantly, the teams suffer that are working with them. So from a provider perspective, non-physician perspective, we're embracing the change. We're going to continue to try to focus on quality and make sure that we can achieve that under the new model. So with that, let's open it up to questions for the team.
Anyone? Okay. I think they were all great. I appreciate everybody. All right? I'm going to have to get you back some way, somehow, though. All right, a couple of things, bookkeeping issues. We're going to ask the members of the SEAL conference to kind of go into their room now. So they're going to get up and leave, and hopefully everybody can help assist in letting them get out with the way the rows are set up. The second thing we're going to do is there is a women's conference at noon in the Oceanside room. Women physicians at noon. That includes lunch. There is also what is it? Blue Earth Diagnostics at noon that also has lunch. And the other thing is, I appreciate everyone, we're trying to stay on time, things like that. I'm going to have some of the staff roll through the hallways when we're trying to get ready to restart a session with the chimes. If you hear the chimes, if you can get back into the room, into your seats, it just makes it easier to keep making sure we stay on time and get everyone out in a reasonable, timely fashion. Is that okay? All right, let's go.